Hi, this is Dr. Mahadevan, and we're going to continue our discussion of advanced airway management. And as I mentioned before, there are 6 steps, or the 6 P's of endotracheal intubation. And in this lecture, we're going to focus on preparation, pre-oxygenation, and positioning of the patient prior to placement of the endotracheal tube. So there's an adage in emergency medicine, which is when you are prepared, it is no longer an emergency. And so preparation is probably one of the most important steps of endotracheal intubation. So we're going to spend some time talking about preparation. What does preparation entail? First, it's protecting you, the endoscopist, from body substances, so body substance isolation. Next, we're going to talk about the mnemonic SOKME and what it stands for, and then specifically go into the kinds of airway equipment you want to collect and have ready before you perform the procedure. With regards to body substance isolation, it's important to know that when you're intubating a patient, you risk exposing yourself to secretions from the patient. So it's very important to have gloves, a gown, something over your head, and a mask, and most importantly, some kind of eye protection that protects your eyes and really your entire face from splashes or secretions that can come from the patient. So body substance isolation, the first step. Next, I like to use this mnemonic, SOKME, to remember the other things I need to have ready whenever I'm intubating anyone. And SOKME stands for suction, oxygen, airway equipment, pharmacy, or the drugs you're going to need if you're going to be intubating a patient, monitoring equipment. And so let's go over the essential airway equipment that you're going to need if you're intubating. So we're going to start with, obviously we talked about gloves and eye protection. This is personal protective equipment. You want to get your suction ready and have it on your right side, tucked underneath the mattress, and make sure that it's working, because you never know when the patient might have eaten or if there's going to be secretions in the airway. And so it can really help you visualize the vocal cords and remove any of those secretions to prevent aspiration. You want to get your actual endotracheal tube ready, figure out what size you need, insert a stylet, and then have a 10 milliliter syringe so that you can blow up the cuff. You need a stethoscope so you can listen to breath sounds after you've completed your procedure, and then a bag mask device connected to oxygen so that you can ventilate the patient before the procedure, after you've inserted the endotracheal tube, and in the case that you're not able to insert the endotracheal tube, you might need to ventilate the patient. So having all these things together is important. In addition, as you'll see, a towel can help align the patient's axes and give you better visualization of the vocal cords. So a towel should be available either to place underneath the patient's head or in some circumstances underneath the patient's shoulders. You want to have an oropharyngeal and a nasopharyngeal airway available in case you need to ventilate the patient. A laryngoscope handle appropriately sized, a laryngoscope blade, either a straight or curved blade. You want to have tape available so that you can tape or secure the endotracheal tube. And then again, we talked about monitoring devices or monitoring equipment. You certainly want to have a pulse oximeter and an end-tidal CO2 detector or end-tidal carbon dioxide detector available. So this is a list of all the equipment that you want to have available every time you intubate somebody. We talked about endotracheal tube sizing. Generally, in the average adult male, you're going to want to get a 7.5 or 8.0 endotracheal tube size. In the average adult female, it's going to be 7.0 to 7.5 in terms of the endotracheal tube size. For children, it really depends on their weight. And so we have a very useful formula for determining what size endotracheal tube you'd have ready for a child, and it is 4 plus the age divided by 4. So for example, in a 2-year-old child, the formula would be 4 plus the child's age 2 over the number 4, and that would equal 4.5. So for a 2-year-old child, we want to have a 4.5 size endotracheal tube available and ready. The other ways of estimating the size of an endotracheal tube in a child are to try and find a tube that fits within the internal diameter of the nostril, and also one that matches the diameter of the patient's little finger. However, in general, I like to use this formula. And a very important thing to remember is, no matter what you determine to be the size that you want to have ready, always get one size smaller and larger. Have it available. You never know until you get down there and find out that the actual cords are tighter than you thought. And if you have that endotracheal tube one size smaller ready, it's going to be easy to have it available and insert it rather than trying to find it at that time in that moment of crisis. An endotracheal tube stylet, as seen here, goes within the endotracheal tube and gives it shape. So it molds endotracheal tube into any shape that you want. It can keep it rigid. What's really important, though, is that it doesn't stick out beyond the endotracheal tube itself. This is very important because it can injure the patient if it's sticking out. So make sure that it resides within the endotracheal tube. You want to get your laryngoscope ready as well. If you're going to do direct laryngoscopy, which means looking directly at the vocal cords, you need to have a laryngoscope. You want to check the handle to make sure that the batteries are in there and they're working, because the last thing you want is for the batteries to run out while you're trying to perform this procedure. Then you want to have the right blades available. The straight or Miller blade, as we'll find out, directly lifts up the epiglottis to give you a view of the vocal cords. The curved or Macintosh blade, as seen here, indirectly lifts the epiglottis by being inserted into the vallecula, and then you lift up and the epiglottis comes along with it when you're lifting up so that you can see the vocal cords. There are different sizes for the Miller and Macintosh blade depending on the age and size of the patient. So you want to get the appropriate sized blade depending on the age of your patient. Again, when we go through our pre-intubation checklist, SOKME is the mnemonic. So have suction available. Not only have it available, but make sure that it works. Make sure that you have 100% oxygen available. Check your airway equipment. Check your laryngoscope light to make sure that it is working. Make sure that your endotracheal tube cuff is not damaged and that there are no air leaks when you blow it up with the balloon. Again, insert that stylet into the endotracheal tube, but make sure it doesn't protrude so you don't injure the patient. If you're going to give medications, if you're going to do rapid sequence intubation, make sure you have your drugs available and that you have IV access. I would say in general, in any emergent patient, obtaining IV access is going to be beneficial. And then think about your monitoring equipment, your cardiac monitor and your pulse oximeter. Have them available, and then make sure you assign someone to watch these things, because when you're performing the procedure, you may lose sight of the monitors. So you want to have somebody who's paying attention to the monitors. Step number 2 is pre-oxygenation. This is a critical step prior to intubation, because while you're intubating the patient, generally that you are not providing ventilations, and so your goal of providing pre-oxygenation is to prevent hypoxia during the procedure. And how do we do this? Basically, we want to create a reservoir of oxygen within the patient's lungs by washing out all the nitrogen and creating this reservoir of 100% oxygen from which the patient can draw from during the procedure. There are a couple of ways of doing this. If the patient is hypoventilating, in that case what I mean is they're not breathing adequately or they're not breathing at all, then you need to breathe for the patient with a bag mask device attached to 100% oxygen. And what you're going to do is, if they're an adult, you're going to give them 10 to 12 breaths per minute for 2 to 3 minutes if they have a pulse. If they're a child and they don't have they have a pulse, you're going to give them 12 to 20 breaths per minute. If you're performing CPR, Regardless of whether they're an adult or a child, you're going to give them 8 to 10 breaths per minute for 2 to 3 minutes to try and pre-oxygenate them. If the patient is spontaneously breathing, if they're already breathing and breathing adequately, then all you need to do is place them on a 100% non-rebreather mask, as seen here, and let them breathe from anywhere from 3 to 5 minutes, and they will pre-oxygenate themselves. And generally what you're trying to do is get them to an oxygen saturation of 100%. And again, this generally takes 3 to 5 minutes, and they're going to wash out all that nitrogen and create an oxygen-rich reservoir within their lungs from which they can draw from. Step number 3 is also an important one. You're going to adjust the height of the bed for yourself. Whether you're short or tall, you want to get the height of the bed to a position where you're not going to be straining your back to perform the procedure. And then you're going to position the patient's head. Generally, when you start, the patient is in the neutral position. And when they're in the neutral position, there are 3 axes. The oral axis, pharyngeal axes, and laryngeal axes are all at angles to one another. And really, it's impossible to see the vocal cords. You'd have to see around this bend to see these vocal cords, which are located right here. Impossible. So your goal is to try and align these axes as best as you can so that you can see through the mouth and visualize the vocal cords before passing the endotracheal tube. The goal is to get the patient in the sniffing position. So let me show you how you do that. The first step in an adult, as I mentioned, is to put a pad or a towel underneath the patient's head. And by doing that, you're going to align the pharyngeal and laryngeal axes. The next step is to get the patient in the sniffing position. As you can see here, it's almost a position of sniffing a rose, okay? So you're going to be flexed at the lower neck and extended at the upper neck. And now what you see is all 3 axes are more aligned, and if you can just get your laryngoscope blade into the mouth and lift up, you're going to be able to see the vocal cords and pass the endotracheal tube. In a small child, generally it's not necessary to use any towel underneath the head. And in infants, because they have this large occiput, we generally put that towel or rolled blanket underneath their shoulder blades. So for adults, it goes underneath the head. For infants, it goes underneath the shoulder blade. And for small children, generally, we don't need to use a towel. Keep in mind, elderly patients generally have pretty bad degenerative arthritis of their necks. Their necks tend to be stiff and immobile, and trying to achieve the sniffing position can be challenging. One thing that you want to really avoid is not forcing their neck into the sniffing position by applying significant pressure. By doing this, what can happen is you can actually fracture their neck and cause a spinal cord injury. So in elderly patients, be very careful. Do not force them into the sniffing position because you can actually injure the patient and cause harm. Also in patients that have sustained trauma, as I mentioned, be very careful about extending the neck. As I've shown you before, in a patient with a ligamentous injury, the bones can move and you can injure the spinal cord, which lives back here. So what do we do in those circumstances? If we're focused on doing the procedure, how do we make sure that the head doesn't move? The way you do it is you have an additional person whose job is right here, is just to hold the head in the neutral position. So person number 1's job is to hold the head in the neutral position. Person number 2 can apply cricoid pressure or something called the burp maneuver to assist you with visualizing the vocal cords. And then you are the endoscopist. You're the one holding the laryngoscope and passing the endotracheal tube. So generally in a trauma patient, I like to say it takes 3 persons at least to intubate a trauma patient. 1 person to hold the head in the neutral position, 1 person to provide a burp maneuver or cricoid pressure if needed, and then you to do the intubation. So let's take a look in real life and see what that looks like. Here is that person holding the head from the neutral position, and you can see in this case, they're actually coming from the thorax, from above the patient, or from the patient's chest. That's fine. Here is the second person providing a burp, maneuver, or cricoid pressure, and then the last person is going to be doing the endoscopy. So again, the first 3 steps in endotracheal intubation are preparation, pre-oxygenation, and positioning.